Three, two, one. We are live now, sir.
Good evening, ladies and gentlemen. Welcome to another exciting episode of the CME titled Blood, the Life Savior.
Manoj, you're muted.
Manoj sir, you are muted.
Am I? Okay. Good evening, ladies and gentlemen. Welcome to another interesting episode 2 of the CME titled Blood, the Life Savior. Today, we have the privilege of having a prestigious institute, CMC Ludhiana, and the topic is Puzzle of Transfusion Dependent Anemia, the tug of war between surgeon and hematologist. As we all know that this webinar will be conducted on Wednesday. We are extremely thankful and grateful to our two program directors, Dr. Biju George. We all know him very well, Professor, Department of Clinical Hematology at prestigious CMC Vellore, and Dr. M. Joseph John, Professor and Head, Department of Clinical Hematology at CMC Hospital, Ludhiana. And a warm welcome to Dr. Chirag Trivedi as well. As you know, this program will start at 7 and we will take close to an hour to conclude the same. Very briefly, I have been asked to introduce Professor Dr. Viju George, sir. Sir needs no introduction, an institution, an authority in the field of hematology and transplant, more than 296 publications in Journal of Repute, and has contributed more than 6 books chapter. And he has also been responsible for developing the innovative protocol for anemia, and sir has initiated 200 plus haploidentical transplant. A lot to learn from sir. And our second program director, Professor Dr. M. Joseph John, sir. More than 30 international and 38 national publications. Sir has been Professor and Head Department of Clinical Hematology at CMC Hospital, Ludhiana, and has done immense contribution to the field of hematology and has laid a very strong foundation for creation of this institute, CMC Hospital, Ludhiana. May I request both our program directors to take it forward from here.
Thank you very much. So we welcome all of you to the second monthly webinars. The idea of this webinar is to do teaching in different aspects of
Biju, your audio is not clear. I don't know.
Can people hear me? Hello, can you hear me?
Better, sir.
Okay. We are planning to go through various aspects of hematology using a case-based discussion. We had the first session last month in aplastic anemia, and now we have the second one from CMC Ludhiana. I would like to hand this over to Dr. Joseph, who is the head of hematology.
It's not coming across, Dr. Biju. It is breaking off in between.
Okay, so I'll anyway hand it over to Joseph to take this forward and initiate the discussion.
Okay. So I think there's some audio problem with Dr. Biju. I'll briefly start the program now. I don't want to steal the thunder from the discussions here. And we have Dr. Vijay Chaudhary, who's our senior resident. His exam going. Though he is just a few days ahead of his exam, he has agreed to fulfill his commitment he has made few months ago. He has done his MD pathology earlier, and now he is doing a clinical hematology and finishing the course. That's a great part. So he will be talking about difficult case of anemia, and we have Dr. Chirag Chaudhary with me. Dr. Chirag is my colleague. He's an assistant professor who had his training in CMC Vellore. He's from Gujarat, and he would be the discussant to the case which Dr. Vijay will be talking. Without much ado, I would request you to proceed with the case presentation.
Okay, sir. Yeah. So, is the slides are visible? Am I audible?
Yes, 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 Vijay.
Okay. So, good evening, all. Today, I will be presenting a case, difficult case of long-standing anemia and the complexities whether to treat between us with the surgical modality or the medical management. So, we in the database we have a 17-year-old girl who is a resident of Haryana. Presented in OPD with complaints of easy fatigability, exertional dyspnea, which is lasting for 7 years. Also associated with the history of black colored stool for the same year, approximately about 6 years. She has a history of recurrent blood transfusions, about 2 to 3 per 3 months she requires, and about total transfusions she received till now when she came to OPD was about 50. She also got admitted with the similar complaints in outside hospital, mostly for the blood transfusion and some work. There was no history of recurrent jaundice, no history of abdominal fullness, receiving blood transfusion from the local government hospital, and also there was no significant family history. Two younger siblings both are normal. So based on the history, we sort of arrive on a differential diagnosis. Our first differential was hemoglobinopathy, of course, then maybe an autoimmune hemolytic anemia. Because there was history of melena, so recurrent GI loss was one of the possible diagnosis because of coagulopathy or some GI tumor or malformation. Then finally, a red cell membrane disorder. So on examination, this young girl has severe pallor. There was no icterus, lymphadenopathy, edema, or clubbing. There was two localized swelling we could examine right on the right shoulder and the gluteal region. Liver was 2 centimeter palpable below the costal margin. Spleen was not palpable, and CVS and respiratory system was fairly known. Coming to the basic investigation, so as you can see here, hemoglobin was 6.3 with low MCV of 65.5, and other two cell lines was fairly normal. RDW is increased to 24. In the biochemical parameters, we can see here all the other biochemical parameters are fairly normal apart from the ferritin, which is reduced markedly, which was 5.1. We extensively evaluated as per our differential diagnosis. So PNH was negative by flow cytometry, coagulation parameter screening, including fibrinogen and RECOF, all were normal. Stool occult blood, of course, was positive. We did upper GI endoscopy, colonoscopy. Actually, was done twice outside also, which was normal. And one outside CECT abdomen report was also normal. So as there was a diagnostic dilemma sort of thing that we have a long-standing transfusion-dependent anemia with GI loss, and there was no obvious lesion identified on upper GI scopy and colonoscopy. So the possibility of small intestinal lesion like angiovenous malformation or possibly a malignancy and a macular diverticulum possibility was kept. So we sort of went to next options. Our next option to evaluate this was radionuclide scan, a capsule endoscopy, or a CT angiography with enterography. And both these modalities, the radionuclide scan and capsule endoscopy, was not available in our center. We went ahead with the relatively easy option of CT angiography. We did that in our center. And of course, that CT angiography revealed few intramural polypoid sort of lesion with intraluminal growth pattern, and of course, they were enhancing. So they reported it as possibility of multiple bowel hemangiomas. These are the CT images. In this image, you can see here, I'll take the laser pointer. You can see here, this is the intraluminal growth pattern, which enhancement you can see here. Another one, similarly, here you can see the enhancing lesion. At that point, we took a pediatric surgery consult, and surgeons were basically wanted to go ahead with sort of diagnostic laparoscopy. So they were not really convinced with the CT angiography report, and they admitted the patient under them and the patient underwent diagnostic laparoscopy. On the diagnostic laparoscopy, also the findings were multiple vascular sort of tumors alongside of small bowel loops, and there was no obvious Meckel's diverticulum. So their main differential here was the Meckel's diverticulum, which was not there on diagnostic laparoscopy. So with all that workup, history examination, and all the investigations, we arrive on a diagnosis of transfusion-dependent anemia with multiple GI malformation, which is leading to chronic blood loss. For the treatment options, we reviewed literature extensively. We reviewed medical versus surgical management, and there were some surgical curative options like bowel resection and medical management in the form of steroid, propranolol, thalidomide, or sirolimus, basically anti-angiogenic therapies. Considering the long-term morbidity which is associated with bowel resection, and since there was multiple bowel hemangiomas were there, a large part of bowel uh, need to be resected to sort of give cure to this patient. So therefore, we started this patient on sirolimus, propranolol, along with the iron supplement. In next 2 months, her hemoglobin has improved from baseline 6.3 to 10.7. And she was completely asymptomatic for her anemia and remained transfusion independent since last 6 months. She also started going back to the school, which she left 4 or 5 years back because of her symptoms. So this is the hemoglobin trend, which you can see. This was the baseline hemoglobin, which when she came to us, we gave 2 PRBC transfusion because she has severe anemia. And after that, her hemoglobin persistently remained 9.5 and above throughout the course without any need of transfusion. With this, I'll finish my case and I'll request Dr. Chirag to take forward the discussion.
Over to Chirag. Thank you, Vijay.
Yeah, thank you, Dr. Vijay. So I will just go through the case discussion. So basically, this is not like a routine case in which we are suspecting GI blood loss, anemia due to GI blood loss. It was a little atypical. Blood loss was definitely there, but initially there was no reason for blood loss. Finally, we have done the CT angio with enterography, and we have found out small intestinal hemangioma. So this GI hemangioma is very, very uncommon vascular tumor that is found alongside the GI tract, mostly in the small intestine, and can extend up to the large intestine also sometime. So we have done the literature review in detail. What will be the best therapy for this kind of condition? So there are multiple syndrome which is described in the literature, which is like face syndrome, multiple lumbar hemangioma, DNH. So this different type of classification they have made. Most common is the face syndrome, the full form of which is posterior fossa abnormality of brain with hemangioma, arterial ectasia, cardiac anomaly, and eye abnormality. So Vijay sir, slowly.
Yes.
So there's lots of other abnormality with hemangioma. So basically this condition can be present with the multiple hemangioma all over the body, and if it is involving the GI tract, small intestine, or large intestine, it can present with blood loss anemia also. Next. So we have done extensive literature review to find out any literature which was available or published literature in this kind of condition. So there were no case, any control trial or case control study. There was only case series, and most of them are only case reports, which was reported by multiple authors. So this was the only, we have find out some around 10-15 study with outcome and intervention what they have done. So most of the patients who presented with this kind of condition were young adult or adolescent age. Most of the patients presented with anemia with GI blood loss, back, and most common complaint with them was the melena. Very interesting to discuss the treatment part here. So generally, if there is a small hemangioma in intestine, small intestine or large intestine, we can very well remove that part and we can do resection and anastomosis. But in this kind of situation, there is multiple hemangioma spreaded throughout the small intestine as well as the large intestine. So the only surgical treatment option here would be large intestinal resection if involving the colon, colectomy, partial or hemipartial colectomy or full colectomy was the most of the author has previously reported this surgical treatment for this type of condition. But recent publication has mentioned some use of medication like propranolol, sirolimus steroid, and thalidomide, basically anti-angiogenic medication that can reduce the new vessel formation and reduce the bleeding. Out of that, the most striking outcome was seen with the sirolimus, single agent sirolimus therapy. There were around 90 to 95% complete remission in published in some literature. Only that these all are case report, no case control or randomized control study. Next. So in our case, this imaging modality to find out this type of rare situation, we have gone through the outside, because the diagnostic dilemma here we have upper GI copy, lower GI copy, everything was normal. Outside CT was also normal. Then we thought the next best option to evaluate here would be either MRI or CT angio. Pinus was very limited, so we have go ahead with the CT angio with enterography, and sometime capsule endoscopy can also be performed to rule out the exact site of the hemangioma or bleeding location. Next. So in previously reported literature in 2011, this one investigator reported double balloon enteroscopy in pediatric population, some case report. So they have done the double balloon enteroscopy with the argon laser, this thing coagulation, and they have treated the small bowel hemangioma. But it was, if it is possible, if only if it very limited spread, and in the large extensive hemangioma, this will be not helpful. MRI is the best treatment diagnostic modality to evaluate any hemangioma or any angiovenous malformation. Regarding our patient, so our patient has underwent CT angiography with this thing enterography, and we have found out there were multiple small bowel along with the large bowel hemangioma was there, although the colonoscopy was normal. Because our patient required repeated blood transfusion with oral iron support also, there was no increment in the blood level. So we thought of where to go ahead.
No,
Back.
the slides are changing all of their own. Yeah.
Okay. Next. So here
There's some problem with the slide changing. Yeah.
Okay. So yeah, our here therapy option we have considered here, because child was around 12 years of age, with considering morbidity, mortality associated with the GI resection and all, we have considered either to give propranolol or steroid or sirolimus. So we thought of, because there was very good data of sirolimus in GI hemangioma, we have started this child with the sirolimus monotherapy sirolimus along with the propranolol. And the dose of sirolimus, next slide. Yeah. Dose of sirolimus we have considered here was we have started with 1 mg per 1 mg BD dosage, and we haven't checked any sirolimus level in between. We have just continued sirolimus for almost around so far 6 months is over. So after 2 weeks we have followed up the patient, and there was very good response with the sirolimus. So I would back. This is the one trial which was published, the clinical effectiveness on safety and effectiveness of sirolimus in pediatric population with complex vascular anomalies. And in this trial, they have back. Next, reported around 60%, 55 to 60% of the patient has got complete or partial response, and 40% has showed stable disease. In our case, we have achieved hemoglobin of almost 10.82 and subsequently more than 10 in subsequent follow-up. So, and child was completely transfusion independent with very good quality of life, and started going school also. Next. So, in conclusion, this case demonstrates the promising outcome and safety and efficacy of the sirolimus in patient with complex GI hemangioma, which can be treated medically very well without any surgical intervention. So to summarize my presentation, so transfusion, so over here 5 point I want to mention. So transfusion dependent anemia with GI blood loss in children should be evaluated extensively. If we are not finding any lesion in upper GI scopy or lower GI endoscopy, we have to go ahead with advanced investigation like MRI, CT, angio, or capsule endoscopy. And small bowel hemangioma, extremely rare condition. With multidisciplinary team approach, we have to do the management. Sirolimus has excellent response rate with 90 to 100% complete remission of and achieving the transfusion independence. And if there is no response with medical management, then only we have to go ahead with the surgical intervention. The last point I want to mention here was, there was surgeon wanted to do laparoscopy. They were thinking there is a surgical case, and hematology has nothing to do with, but ultimately it was GI hemangioma. So there should be good coordination between surgeon and hematologist or physician as far as this type of atypical case is involved. With that, I would like to thank my mentor, Dr. Joseph John, and all my entire team of CMC Ludhiana for giving the opportunity to present and discuss this case.
Thank you. Thank you.
Yeah, thank you, Vijay and Dr. Chirag for this discussion. So basically, when you come back, and can you just show the CBC with that MCV report there? So basically, the take home generally would be, and I would put both Vijay and Chirag on the spot to answer some of my questions, and then there are questions in the chat box which is coming in. So we are saying that, okay, young lady, young girl with anemia, which is blood loss anemia. There is proven iron deficiency, menorrhagia is not there, and therefore you rule out a possibility of fuse Jaggers there as a first possibility. Now here we are getting hemangioma. Now you're, I mean, rightfully sirolimus has done the job. So I have two questions to you. Sirolimus is an mTOR inhibitor. How does it work um, in resolving the angiodysplasia? Number one question. Second is, we know that the cardiac stents are sirolimus drug-eluting stents or rapamycin drug-eluting stents. There we are harnessing a anticoagulation effect. So how do we balance this out, and what could be the possible postulate mechanisms written in the literature?
To
Should I tell, sir?
Yeah, go ahead. Go ahead.
Yes,
Either
sir.
of you.
So sirolimus, as far as all we know, sirolimus is a mTOR inhibitor. So the property they have described in this, it has two main property. One is anti-angiogenic properties. So it reduces the new vessel formation by some mechanism of inhibiting molecular level inhibition of vascular endothelial growth factor and revascularization. And the sirolimus eluting stent, as far as I know, sir, this mechanism for this drug eluting stent, it it is not for anticoagulation, but it prevents the intimal proliferation of the media, means vascular media. In that means it prevent the vascular growth of the plaque or the smooth muscle. They prevent the progression of plaque formation. What I understand, the drug-eluting stent.
Sure. So Dr. Biju has a very pertinent question. Thalidomide is considered anti-angiogenic and anti-inflammatory. And why not thalidomide and why sirolimus?
So there was no direct any means we have chosen sirolimus just as the first option. There was no any reason to consider means why not to consider thalidomide. We thought because the some case report, 2-3 case report has reported excellent outcome with sirolimus. Thalidomide, there was some data, but the maximum outcome around means 80-90% was with the sirolimus. So that's why we have go ahead with the sirolimus, sir.
So higher rate of response to sirolimus,
Yes, sir.
therefore you chose and it worked out well. Thalidomide may have worked out well, we don't know. Okay. So
Also,
second
sir,
question is, sorry, Biju, Dr. Biju.
Sir, Vijay is here. So, sir,
Ah,
actually, the safety profile also we took into consideration looking at the literature. The sirolimus safety profile is much better than the thalidomide itself. So, that point of time, young girl, we would like to use sirolimus as a first choice rather than thalidomide.
So then two major concerns come up now. How long will you continue this, and when would you want to do an interim CT scan to know the response? Any thoughts on this? What does the literature say?
So 3 to 6 months are basically literature says that 3 to 6 months the regression they say of angiovenous malformation. So a repeat CT angiography would should be done at around 6 months or 7 months at time to see the clinical response is definitely there, but we need to see the objective response in terms of the regression of hemangiomas also.
So what is the literature say about the duration of continuing the these sirolimus?
Chirag sir, would you
Is
like?
there no
Yes,
no
sir.
Dr.
So
Chirag or Vijay?
yes, sir. So in the whatever published case report, they have given sirolimus for minimum duration of 6 months to 1 year, sir. Most of the time means the gastric hemangioma may tend to regress with the use of sirolimus also, but because it is only case report study, there was no clear-cut guideline when to stop. Means they haven't mentioned when to stop, when to reevaluate. But they have just the 2-3 case report. They have mentioned just to continue sirolimus 6 to 1 month, taper and stop if there is means
No further thing. Okay, so once you get a CT resolution, probably we can continue for another
yes,
2-3 months and then taper, stop it, and repeat it in case there is symptoms. I mean, that will be a most practical approach since there is no large series on this.
yes.
Uh, shall we throw some light on iron supplementation in an iron deficiency anemia case? In a scenario like this, we have to take two things parallelly. One is the corrective and the preventive action. Preventive action you have done with sirolimus in terms of the corrective action for the iron deficiency. How long, how much?
So
Yes.
basically, we have to give iron therapy because there is ongoing GI blood loss for quite a long time with depleted iron store. So we will give at least iron for 6 months. Anyway, bleeding has stopped. Now there will be no further GI blood loss. So minimum 6 months of iron therapy along with the sirolimus, and we will monitor monthly with the hemoglobin level as well as MCV and MCH. And accordingly, we will titrate the dose of iron accordingly, sir.
Sure. So for the participants who probably tuned in late, we are dealing with the GI angiodysplasia causing long-standing iron deficiency requiring transfusions. All investigations pointing towards an iron deficiency state, and then the CT scan has shown multiple angiodysplasia, CT angio, which is showing angiodysplasia. Sirolimus was given to stop. Again, the iron basic principle 6 mg per kg is the correction dose in terms of putting the HB back on track. Once the hemoglobin is recovered, we have to give another 6 months to improve the stores. So 6 mg per kg oral. If you want a rapid increase, IV can be given. And so it's just, iron deficiency with a twist to say that, okay, there is hemangioma and not polyp and GI loss. And improved with sirolimus. We could have tried thalidomide and continued with oral iron. I would request Dr. Biju to give his experience in similar cases and any other thoughts along the way.
Yeah, thank you, Joseph. It's a very interesting case because I think two things I think teaching learning points. One is we make a diagnosis of iron deficiency, we shouldn't stop just there in terms of just treating. Somebody who's unless you're very clear that it is diet deficiency related iron deficiency, we should evaluate for why that patient or child has developed iron deficiency. And this is a very nice, thorough, step-by-step workup for evaluating for a cause. So I think that is important in our clinical practice because I see quite a bit of patients who come who are just treated and never evaluated. And so that I think is something which should be avoided in clinical practice. Two, yes, even we are using more of sirolimus now in our patients where we diagnose to have angiodysplasia or vascular anomalies. Because of mainly the safety profile and also looking at the age, because earlier we used to use thalidomide, but the worry is the constipation, the sedation. Then if you are a young married person, then the worry about pregnancy and the fact that if to have contraceptives in place. Because of that, we have also shifted over to sirolimus. Now,
so we will stop 1 sec. So to continue, sorry to interrupt you in between. Just for the listeners, can you expand on the dosing and the evaluation in terms of fasting lipid profile and other parameters while on sirolimus?
While on sirolimus. So I think when the patients where we have used sirolimus would be between 1 to 2 milligrams per day. So it's low dose. We are also not going by sirolimus levels because we may not need the dose that is needed for complete immunosuppression for its anti-angiogenic effect. Now, I've got a patient with the Klippel-Trenaunay syndrome who's on actually sirolimus. It has taken 6 months actually for some reduction. So the time period, I'm not entirely clear. I'm going more of it clinically to see whatever lesions we have which are measurable, to see when it would come down reasonably before we try and stop it. The second important thing would be to keep these patients under evaluation after you decide to stop the sirolimus to see whether there will be a breakthrough. So it's very important that you have to follow up. So this patient, once you decide to stop, you could just monitor hemoglobin and stool local blood, and it will give you a reasonable idea in terms of whether they have started to bleed again. And if they've started to bleed again, you can be reasonably sure that the angiomas are back. But how long? And that is why I asked this question about CT, whether you would wait for complete resolution of all the vascular anomalies that you see on the CT scan before you decide to stop sirolimus. I mean, I don't think there is anything put hard in stone, because these are far and few case reports. We just have to go by experience. I would say we should stop sirolimus only after we make sure that almost all the vascular anomalies that you've seen have almost completely regressed. Otherwise, you have the risk of relapse once you stop it.
So we have Dr. Pavitra online asking a very pertinent question. Can we use other mTOR inhibitors like everolimus if at all you want to consider? Now, this is maybe conjunctural, or you can put two and two together and say probable. Any thoughts on that? Everolimus versus sirolimus.
Yeah,
Chirag, in your review, did you see any everolimus being
no, sir.
used?
So in data, nobody has given everolimus. Only 3-4 case report using of sirolimus. Everolimus nobody has used. But I think as per the rationale we can use, because same class of drug, same mechanism of action.
So can I just come in? So I think there are some
Please.
case reports on using it in angiomyolipomas and facial angiofibromas with exactly the same theory in terms of them at low level helping in reducing angiogenesis. So it may work, but I think theoretically it should work because it's the same mechanism that you're looking at.
And are you doing once a day or twice a day sirolimus dosing strategy?
We are using once a day.
Once a day. And are you evaluating fasting lipid profile like we do in transplant patients?
In the patients that I had, I did it once after a month, but I don't do it regularly because what we are using is low dose sirolimus and not at a level where we want to get our levels between 5 to 10. So if we may not be able to. So trying to get these patients to do lipid profile and look at the triglycerides every monthly is very difficult, but probably once in 3 to 6 months, we should be monitoring it, especially if you are looking at very chronic therapy.
Okay. So any other questions from the audience, faculty, any other loose ends,
So,
sharp
Joseph, I
ends to
think
be
there is a second question from Dr.
Hmm.
Pavitra asking what is the duration of sustained response after stopping the drug. So, Chirag, in your literature review, are there patients that have stopped the drug, and have the authors commented on how long patients have remained well after stopping the drug?
Sorry, sir. Means I haven't found that data. They have just case report. They have just reported the response rate, and I tried to find out, but there was no how much was like sustained response data in that particular case report, sir.
So Dr. Pavitra, I should say that I don't think there is enough data available in literature that is described to answer it, because we just do not know. We do not have, maybe there are patients where drugs were stopped, then what happened to them, we do not know. So we will not be able to answer that right now. There's a
So
question
meanwhile,
from Ramesh.
yeah, go ahead, go ahead.
Have
Yeah.
you used sirolimus and hereditary hemorrhagic telangiectasia? Any data?
Yes. We can use it. Is like same I have mentioned that hemangioma and angiovenous smart formation. So sirolimus will have very good response with hereditary telangiectasia also.
So Krishna has asked another question on bevacizumab, use of bevacizumab or octreotide in HHT.
Yeah, so means I also don't know. I have also doubt when we were considering the treatment because bevacizumab is a anti-VEGF antibody, but nobody has used so far, and nobody has reported the use of bevacizumab even in when we are talking about von Willebrand disease, when we are giving thalidomide as an anti-VEGF, but nobody has used bevacizumab. I don't know, means.
So generally, beva is used, at the local site. Ophthalmology is used in the retina or that another congener of the bevacizumab they use. Yeah, I mean it's maybe it's an opportunity for Chirag to do a systematic review and put all the data which is there together now. Now that you have done extensive, search on this.
Yes.
Okay, so any other questions? So there is Pavitra has replied, thanking everybody.
I have
So
one
Dr.
doubt, sir.
Biju,
I want to ask
go ahead.
Biju, sir. So means I
Ah,
was also thinking to use vincristine if there were if sirolimus no response. Whether means we have in CMC we have used vincristine and sirolimus combination also for some patient of this hemangioma limb hemangioma and so we could
See,
vincristine
so
can work here.
honestly, I would say I don't think we have used a combination of vincristine and sirolimus. I know in the past, quite some time back, maybe 10, 15 years back, when we used to use thalidomide, those who failed thalidomide, we have used Vinca alkaloids. I don't remember very well whether they worked or not, but I think now we hardly ever use, because the response to sirolimus actually is much better, much better than what you see with thalidomide. So we haven't used this combination of vincristine with sirolimus.
so Dr. Anushri says she has used octreotide in reduction of transfusion requirement in HHT. So maybe she can share her thoughts. Can you just upgrade her to a panelist so that she can answer these questions? She can share her experience actually. Anushri, are you there? In your experience, you have used HHT octreotide in
Vinny,
30
can we do
mg once.
that?
So I think the problem is the
Yes, ma'am.
attendees are
Not on the panel. Okay, no
they don't
problem. So
come
she
into the
has said she
panel.
has used IM octreotide 30 milligram once a month and improved in HHT. Okay, so when you have pushed to the wall, you have options like this to use. Obviously, you have earlier we used to use low dose progesterone. Then we use thalidomide. Now we have sirolimus, everolimus. We have probable octreotide also. So maybe it's an opportunity for Chirag and Vijay to put these
Sir, she is in the,
publications.
she is there. You can ask.
Oh, she's there and she can respond. Why
Yeah.
not respond?
Hello?
Please unmute.
Hello?
Yes, go ahead.
This is just one experience. So this patient was having refractory GI bleed requiring transfusions every week. This pelagic telangiectasia familial, along with retroviral disease, along with tuberculosis and brucellosis together. We were having a very tough time. So rather than using an immunosuppressive therapy, I decided for this, and this significantly helped for IM octreotide, significantly helped to reduce the transfusion requirement.
And Dr. Anushri, can I just ask, so how many doses did you end up having to use to sort of get this transfusions down?
Sir, she's still continuing. We are not able to stop it.
Okay.
It has been nearly a year now.
It's been a year now.
Okay. Dr. Biju, shall we call it a day if no other questions?
Are there any further questions if anybody has? Okay, this today's session actually demonstrates the beauty of case discussion, because we started with GI angiodysplasia, we talked about octreotide, we talked about HHT, and where we can use that. So I like to thank the team from CMC Ludhiana, Dr. Vijay Chowdhury, Dr. Chirag, and moderated by Dr. Joseph to help us get through this. And so I think for everybody in the audience, I think the learning points are, when you get the iron deficiency, do not stop there with just treatment. You need to evaluate. And I would say, in my experience, there have been times when the first set of endoscopies and colonoscopies have not shown anything. Then you just continue treatment, but keep periodically on follow up. They will come back later with one more bleed. You evaluate at that time, you will find something. So it's sometimes a continuous exercise. So don't be disheartened if you don't find anything the first time, because you will probably end up finding it later. With this, I will hand over to Joseph to give some comments, and then we will hand it over to Intas.
Thank you, Biju. I think you have concluded it well and rounded up, and with the take-home points there. And iron deficiency is one of the commonest OPD symptoms you need to tackle in the OPD, and we can't take it lightly. And of course, we have patients having pica, all sorts of things. Very interesting if you go into the iron deficiency. Just to share, I mean, I heard it recently. How did the word pica come in? So apparently, one of my house doctors who presented the case, I never knew it all the way. Pica comes from the word pika pika. There is a bird which actually eats anything and everything called pika pika. So that is how the word came pica. So just to share some interesting anecdotes on iron deficiency as such. Okay, over to Arun and team. To conclude, we have about 11 minutes to spare, and
Thank
everybody is
you.
hungry and have
Thank you very
evening
much,
time.
sir. Thank you, sir. Today we are incredibly grateful to all of the participants, those who have joined us in the Blood the Savior. We are successfully completed today the second episode of this insightful web series. And on behalf of Indas Pharmaceutical, I, Arun Chadha, Vice President of Indas Pharmaceutical, extend a heartfelt gratitude to all our esteemed delegates, those who have joined us in this second episode. And a special thanks goes to our esteemed course director, Dr. B. Joseph and Dr. Joseph Johnson, for designing such a fantastic web series, especially on blood. This program will undoubtedly a valuable resource for all the students, DM and DNB students, and all other students also. And we are incredibly grateful to Dr. Vijay Chaudhary for sharing their insightful case presentation. And we are very much thankful to Dr. Chirag Trivedi for localization of this case and giving the insightful of this case also. Further to this, because this case comes from the CMC Ludhiana. So we are very thankful to Dr. Joseph John, who is the head of the Department of Hematology, CMC Ludhiana, for giving the insightful of this case and providing all the learning points and summarizing all the proceeding of this unique case. Once again, a heartfelt thank you to all of you for your gracious presence, and it's being a true pleasure being with all of you today at the second session of the Blood of Savior. We are very thankful, and we will definitely expect and eagerly waiting for you to return for the next highly anticipated session of Blood the Savior on March 19th. Until then, stay safe and take care. Thank you. Thank you to all of you. Thank you, sir. Thank you very much.
Thank you.
Hi, everyone.
Bye.
Thank you. Thank
Great.
you.
Thank you. Thank you.